Hi, everyone. Thanks for joining us. We are talking trauma today, and each year, traumatic injuries account for more than 40 million emergency visits, or emergency department visits, and affect 2.3 million hospital admissions across the nation. It's a lot of numbers there. But because trauma is a disease that affects all ages, people from young to old, the impact on life years lost is equal to the life years lost from cancer, heart disease, and HIV combined. Joining me today is a panel of medical experts from Baylor Scott White Health who are here to discuss the topic of trauma. You guys want to go around and just introduce yourselves real quick?
Hi, I'm Mike Foreman.
And what do you do, Dr. Foreman, for people who...
Sorry, I'm a trauma surgeon here at Baylor. I'm the director of trauma surgery.
Great.
Hi, I'm Anne-Marie Warren. I'm a clinical psychologist at our Level 1 Trauma Center here.
My name is Karen Miner, and I'm a registered nurse in the emergency department.
Great. Now, obviously, trauma is both physical and emotional event, but let's talk about what trauma is in the medical sense first. Dr. Foreman?
The word trauma refers to what happens to the body when an outside amount of energy is applied to the point where the tissues can no longer deal with it. And so there can be a variety of different ways that can happen. You can trip and fall going up the stairs, and your nose will be traumatized as it impacts onto the stairs. You can be in a car wreck, and as the car decelerates and you're in the car, you're also injured. So any mechanism that supplies enough force to the body that ends up creating tissue damage is trauma.
Great. And also, let's talk a little bit about the other aspect where we often hear people say they were traumatized. You don't hear them talking about their nose so much. They're referring to something else, maybe on the emotional level.
Sure. When we talk about trauma, sometimes people do think about other kinds of trauma, for example, sexual abuse or those kinds of things. But we do know that physical trauma and injury, like we see here at our Level 1 Trauma Center, produces a unique kind of psychological response to trauma that has some different elements than other kinds of psychological trauma.
Interesting. So what are some of the most common trauma injuries that you see coming into the emergency room, Dr. Foreman?
Well, the most common cause of injury that we have that are admitted into the trauma center itself are caused by falls. I think people forget just how common that is as a mechanism of injury. We think about a fall being something that happens to the elderly patient that gets tripped by their shag rug and falls over and injured something. But it occurs at all ages. Gravity really doesn't care who it is that's pulling down. And so that's the singular most common reason that we have patients that are admitted. We see a lot of patients injured from motor vehicle collisions. We see motorcyclists, we see bicycles, and of course then there's the interpersonal violence. But any activity that you do, or in some cases don't do, at least has the potential to lead to injury.
Now, that brings up actually a question that we were talking about a little bit, which is that no matter which type of trauma it is, whether it's a fall or interpersonal violence or injury, there can be psychological components to that are trauma related, regardless of what happened.
You know, it is true, and it's interesting because the research, the logical person might say, well, depending on the severity of trauma, so for example, if someone has a gunshot wound, they might be more traumatized emotionally than someone that maybe has a fall and breaks a leg. The reality is, as we know from our research and other research, that the severity of trauma does not necessarily predict the emotional response. Everyone is individual and they deal with trauma very differently.
Now, from the nurse's perspective, Karen, I'm turning to you now. Do you see the patients who come in after some sort of trauma injury first? Are you the first person to see them?
Generally speaking, yes. When people come in, they can come in either on their own means or they come in through the ambulance system, and they'll be assessed right away, usually by a registered nurse. And we're the ones that set the acuity or determine the severity of what's going on and where that patient needs to go next.
And how do you do that assessment? What are you looking for?
Well, a lot of it has to do with it's a systemized triage system that's been put out there after a lot of research, and it's actually very organized. But we basically look at things like, is their airway okay? Are their vital signs all right? How life-threatening is it, and how fast does any intervention needs to be done in order to sustain life?
Now, what are some of the first steps that should be taken if there's some sort of traumatic injury, whether it's a fall or someone is cooking and it's a burn, or whether you see someone and it's a gunshot wound? What are the first things that you should do in that situation?
Are you referring to the person who would be assisting?
Yes, the person who is there as sort of a witness to this event.
Well, the first thing I would recommend is that you make sure that you are not entering an unsafe situation, because if you do, as the rescuer, you could not only increase the number of victims involved, you could make things worse for the person involved. So the first thing you need to do is make sure that it's safe for you to intervene. The second thing you need to do is call for help, because one person alone is not going to fix that situation. And there are different levels of Good Samaritans out there. You've got your people that are actually trained first responders. You've got just your normal person walking down the street. And then you've got people who are medically trained. They're out in the community. So I usually just tell people, just do what you feel that that any normal person in your situation with your amount of knowledge could reasonably do. And that's all we're expected to do.
Now, if you're the person who's had a traumatic injury and you maybe aren't able to call for help immediately or something, obviously that's the first thing, one of the first things you should do. Say you have a cut, what is the first thing that you should do in that situation?
Well, the first thing you're going to do is maybe wrap it up and apply a little pressure. I would recommend that highly. The second thing is that if you feel like you can't get to help safely on your own, call for help.
Now, in coming into the emergency department, Dr. Foreman, do you see a lot of people who have had assistance? Are they coming in on their own? And do you see things that maybe you say, oh, I wish you had done X, Y, or Z?
Well, absolutely. Oftentimes it's more along the lines of, I wish you hadn't done X, Y, Z.
Yes.
As you know, one of our common presenting issues is, hey, watch me do this, hold my beer. And that leads us to a whole set of circumstances that we wish we could have avoided. When you get right down to it, all of trauma goes back to preventing it from happening in the first place. It's much better to do that.
What kind of trauma can you prevent from happening in the first place, in addition to the watch this while I hold my beer? I mean, for falls and things like that, is it assessing the home and trying to make it a safer place, that kind of thing?
Well, if you think about it, really almost every injury is potentially preventable. It's very difficult to come up with a scenario that you couldn't have potentially stopped the injury from having, or then again at least mitigating the effects of the injury. That's one of the reasons why, and everyone that knows me will cringe when I start to tell you this, but we don't allow the word accident to be used. Because an accident implies it's an act of God, it's something that you can't do anything about. And specifically if you think about what happens on the roadway, even if you're obeying all the laws of the road, the guy who isn't, that plows into you and causes injury, that was completely preventable. And so, seat belts and airbags and better engineering in cars, for example, are fabulous. But they're not as good as not having the wreck in the first place. The throw rugs that we talk about at home, the cat that runs between your legs. I mean, all of these things can end up causing that type of a process. If you're out doing something you shouldn't have been doing and you get involved in a violence situation, it's amazing what a few less beers does to people's temper. And how that intervention then leads on. But as was earlier alluded, I think what you do depends upon what your level of training is, and you take care of yourself as best as you can. We see, as a trauma surgeon, the emergency department has already sort of selected out the minor injuries. We don't end up seeing the minor injuries very much. It's the more significant injuries that we get involved with in the first place. And so we get a call that says, come on down, and that's what I was doing actually right before we stepped in here, of someone that was seriously injured, and we go in and assess them and start caring for them immediately.
Now, I saw in some of the stats on traumatic injury in Texas from the last, I believe it was the last year, reports that the majority of trauma incidents occur between people who are the ages of 25 and 34, and then seniors 75 and 84. So what is it that the people in their 40s and 50s and 60s are doing that's keeping them from ending up in your operating room?
I don't know the answer to that. It's probably just a bump on the population board at this point. Many years ago, when I first started, it was said that trauma was a disease of the young and vigorous. Well, as we all know, age is a very relative thing. We have 80-year-olds that are bungee jumping, and seriously, I mean, if you think back historically in our population, there weren't a lot of 80-year-olds jumping out of airplanes and doing other things, and that translates through. I'm stupid enough that if given the opportunity, I'd probably go out and try to play a little touch football over the weekend, and I'd be in the emergency department very shortly thereafter because I have absolutely no cause to be doing that. But I do think that what we're seeing is that as we are aging a little bit better than what we did from our previous generations, that you're seeing this sort of bubble of activity. And if you're 45, don't think you're safe.
Good advice. Now, Dr. Warren, when is the right time to begin turning to the psychological aspect of trauma for someone who, say, comes in for a gunshot wound? Obviously, the medical needs seem to take precedence, but when do the other aspect come into play?
That's a great question. We address that as early on as possible. So for myself, I usually am seeing patients even as soon as they're stable and in the intensive care unit. What we do know is psychological reactions to trauma can happen as soon as the first 24 hours, and we call that a traumatic stress reaction. Within the first 48 hours, we call it acute stress disorder, and then a month later, we call those similar traumatic reactions post-traumatic stress disorder. So there's kind of a continuum of psychological response post-trauma, but it's really important to identify and address traumatic symptoms early on, because what I find is that when we give patients education about what's happening to them, their inability to sleep, nightmares, anxiety, and help normalize that as a part of trauma, then that alleviates those symptoms to hopefully prevent them from having more problems down the road. So we really try to educate and intervene on trauma as early as possible from the psychological perspective.
Now, Dr. Foreman, do you notice any difference? I mean, I imagine that in the past, maybe there wasn't such an emphasis on looking at the psychological aspect in the beginning. Do you notice any influence in terms of recovery with that?
Absolutely. And I will tell you that our eyes are being opened as to just how important this impact of the psychological piece is. I've been in practice, as you can see, for a long time. And Dr. Warren and I have had this discussion as she began her studies looking at the incidence of psychological problems with our trauma patients. Had you asked me, I would have said, well, it's probably something I see in, maybe 3% of my patients, I would guess, end up having PTSD. Then we studied it and we found that it was 30% of the patients. It's massively underappreciated. We are very lucky. They're one of the few level 1 trauma centers that have the services of someone like Dr. Warren to help deal with that end of the spectrum of our patients. And does it affect their recovery? Does it affect their progress through the hospital? Absolutely. just like any other aspect of your life. If you're being debilitated by depression, by anxiety, by any other piece of that, it makes everything else harder. It's hard to get up with a physical therapist and walk on a broken leg that's been fixed, and when you've got 6 ribs that are fractured and a tube coming out of your chest, that's hard to start with. If you take that same patient and give them significant anxiety related to the fact that they were hit by a drunk driver while they were taking their kids to school, it makes it that much harder to get out of bed. It makes it that much harder to reclaim your life. And that's what this whole process is about, is trying to reclaim your activity, reclaim your life. Aftermarket parts are not as good as factory parts. And so if we can prevent you from having that scar, we can prevent you from having that injury in the first place, that's far better. But after we fix it, there's still a lot of recovery that goes on both in the mind and the body.
Now, this question is really to anyone. It seems like traumatic events, the incidence for men is higher than women. Is also the type of traumatic injury different by gender as well?
I'll take that. I have said for a long time that as long as we don't run out of gravity, gasoline, alcohol, and testosterone, that I will always have work to do.
Well, there are plenty of low T centers and so on around to keep that one of those things in supply.
Maybe that's that bubble at 45 that you were talking about. Maybe that's where that's going to come in. No, if you look by and large, especially with risk-taking activities that end up leading to injury, if you've got a teenage son and then you have a teenage daughter, you can pretty much weigh the average as to which is more likely to go out and do something stupid that's going to get them hurt. I've had both, and I can tell you that remains true. Now that they're in their 20s, I'm not sure that has changed. So males, by and large, they tend to go out. They, especially if you start looking at things like violence. The incidence of violence is much higher in males than it is in females. The incidence of doing all sorts of crazy things that's testosterone driven seems to be higher in males. And as a result, we have a higher incidence of males coming in to see us.
Now, I know that with falls, and like you said, falls are the top result or cause of traumatic injury for people in Texas and I think across the nation as well. The greatest predictor of falls is previous falls. Is there some sort of component in terms of counseling or also home services to try and prevent future traumatic injuries after one has occurred?
Can I speak? I'll speak to that one because we assess every patient for a fall risk when they come to the emergency department. That's a standard of care that you'll find across the country, and we actually weigh it on a scale to see what patients' risk factors are. Are they incontinent? Do they use a device? Do they fall before, et cetera, et cetera? And we do fall prevention while they're in the hospital, and then we do teaching afterwards. And if they fall within a high risk or moderate risk or even a suspected risk, we can refer them to any number of services, even within the emergency department, to get them home safely or to help them maybe a little bit more, whether it's going to be rehab, maybe even just something as simple as having a walker available, that type of thing, or just education within the family. We try to take care of that before they leave so that we know that they're going to be safe going home, getting there, and then hopefully that it might prevent something in the future.
Now, Dr. Warren, what is a normal response to a traumatic injury, psychologically speaking?
So again, everyone is an individual, but we typically see people have trouble sleeping, they have increased anxiety, they might be thinking about the event over and over again and unable to get it out of their mind. They might have things that remind them of the injury. Those kind of symptoms we kind of expect to happen, and we do try to normalize that through education. Where it becomes a problem is if those symptoms increase in severity and last for really a period of about 30 days or longer, and when those symptoms affect their relationships, their ability to return to work, their social functioning, then again, we look at are they diagnostic of post-traumatic stress disorder. So it's that fine line of there is a normal response to trauma. Actually, sometimes when I see people who have no response to what's happened, especially if it's a pretty severe trauma, that actually makes me a little more concerned because I always tell patients that the emotions they don't need to go away. They're going to come up at some point. But so we do try to normalize this is part of trauma, but we want to monitor and make sure people have resources if those symptoms don't go away or get worse over time.
What are some of those resources that people can turn to if they aren't maybe in the hospital, maybe they've gone home already and they're looking for something online? Where might be a good place to go?
Yeah. There's some great online resources from an educational standpoint. For PTSD in particular, the National Center for PTSD is a great online resource for folks. It's got a lot of information about coping and self-help. For patients here, one of the things we try to work on is getting them hooked up with a psychologist or psychiatrist as needed in the community. So we really work on individual needs for a patient or family who is also experiencing their own response to the patient's trauma.
Now, Dr. Foreman, like you said, it doesn't seem like anytime soon traumatic injuries are going to disappear. Young people are going to stop choosing to do things that maybe they should not be doing, or old people as well. You're not going to be out of a job. So what can people do to prevent both their people in their family and themselves from having a traumatic injury?
Well, one of the hardest things that you can ever try and teach somebody is common sense. There are a whole variety of one of the things Dr. Warren was talking about earlier is this response that everybody has where you tend to have the incident running back through your head saying, gosh, how did this happen? Why did this happen? Why did this happen to me? That's a normal response. And if you think about it from an evolutionary standpoint, that's how we learn not to do things. When you're a baby and you touch the stove and you burn your finger, you figure out maybe touching the stove with your finger is not a great idea. So, if you look at what things happen commonly, if you look at motor vehicle collisions, just the simple act of putting on your seatbelt, as boring as that seems, it saves lives. Having the sense to not, how important is it to make that meeting that I'm 5 minutes late for? Is it worth pushing that yellow light? If you're going to go out and you're going to enjoy alcohol, enjoy your alcohol, but then don't get behind the wheel of a car when you're coming home. There's a whole variety of things that we can do that are just sort of common sense processes. If you're out, I'm not sure why people trim trees at night. You would be astonished at the number of patients that we have that come in that have fallen out of trees at night when they were in the tree trimming the tree. I know you're going to be very surprised that sometimes alcohol is involved in this situation, but it's one of those processes where you just say, why would you do that? And to the individual, I'm sure at the time it made sense, but it helps if we remember that we're not invulnerable. It would also help if we didn't use Hollywood to make us make medical and behavioral decisions. There's a surprising number of people that decide they can jump out of cars to get away, and it looks great on Hollywood where they just jump right up and walk right off and continue with their lives. And I'm telling you, if you come out of a car at 30 miles an hour, it's not pleasant. You're not going to get up and walk away from it in all likelihood. So again, just some better appreciation of it. I'm continuously amazed with just how sturdy human beings are and what they can get through. But it's also impressive how little it takes in some situations to break yourself irreparably.
Now, there's one other question I wanted to ask about the term, and I know people can go for more resources to the Facebook group that is facebook.com/group/trauma stat. What does the STAT stand for? That's an acronym that I think is an important one.
Go ahead. Sorry. Well, STAT is a term that we use for something that is in medical that has to be done immediately. And they've brought that over. I think Dr. Warren was the one that originated using it as the point. So it's surviving Texans. Help me out here, Anne-Marie.
Someone knows the answer.
Saving Texans after trauma.
There we go.
Yes. And so what? Are there also, Dr. Warren? Are there specific that go along with STAT? Are there specific things that you would say people should make sure that they follow protocol-wise? I know every situation is different, but is there advice on that in this Facebook group or online?
Yes.
Yeah. Oh, and I was just going to add, what we do on that is we not only post information about different types of trauma, injury prevention, we post a lot of information on that, but we also post about what it's like after someone sustains a trauma, such as a traumatic brain injury or spinal cord injury, to give additional resources for people whose injuries may not be a couple weeks, they may be dealing with these injuries for a couple of months or a lifetime. So we try to provide all types of resources on our Facebook group to give them that information.
Great. I think we're going to wrap up. I want to say thank you to our panel of medical experts in this discussion on trauma today. And if anyone watching has further questions, you can find more resources both online at that Facebook group I mentioned, which is just facebook.com/groups/trauma-stat. And of course, you can follow Baylor Health at Baylor Health or on Google+, Twitter, or Facebook. So thank you again.
Thank you.
Thank you very much.
Thank you very much.